Hi, my name's Professor Peter Nash from the Griffith University in beautiful downtown Brisbane in Queensland, Australia. And today we are very fortunate to be joined by Professor Francesco Ciccia, Assistant Professor of Rheumatology at the University of Palermo in Italy. And Palermo is a very beautiful city. I'm pleased to let everyone know that this Rheumatology Author Interview podcast has recently won an award at the 2021 Spring Digital Health Awards. So make sure you subscribe to the CSF and keep yourself up to date. Welcome, Francesco, and thank you so much for giving up your time to join me. You tell me you're in Naples at the moment. So tell us a little bit about yourself, a little bit about what work you've been doing, and maybe even how COVID has affected you, your family, and your work.
Thank you, Peter. Thank you very much for this for inviting me to this very amazing appointment. I moved from Palermo in the last year, and now I'm working at Naples. Not sure a big difference because Palermo and Naples were the two capitals of the two Sicilies kingdom in the past centuries, and we share the same culture in terms of life, food, and wine, and so on. So I'm essentially worked in the past 20 years on translational aspects of pathogenesis of rheumatoid arthritis, but mainly spondyloarthritis, and actually I'm continuing to work in these fields also in Naples. The COVID pandemic was terrible also in Italy. Now we are trying to restart normal life, but with a lot of problems, a lot of very complicated situations. But anyway, we are fighting to start again. Start again a normal life and the normal world.
And tell us what you've been working on recently that led up to this particular review paper that we're going to be discussing, recently published in the Clinical and Experimental Rheumatology Journal.
Yes, we have started to use in Italy the JAK inhibitors in the past 3 years, and what we have observed according to the published clinical trial is the dramatic effect on pain of our patients. And since the pain is the most important symptom that the patients that push the patients to come to consult rheumatologists, we asked why JAK inhibitors might be so potent, so powerful in inhibiting, in modulating pain. And we have started to study from translation part these aspects by studies the small fiber disease in psoriatic arthritis patients at baseline and after JAK inhibitors, and we are continuing on studying this specific aspect. But in this article we have reviewed the recent evidence indicating that JAK-STAT pathway might be not only involved in modulating pain by directly modulating cytokine production, cytokine expression, but also by indirectly modulating pain, directly modulating pain, acting on nociception, the transduction of the pain signal.
So is pain a big burden in RA, do you think, with all the modern therapies? Is it still a big problem, particularly people with damage and...
Yeah, pain is the most important, the most common symptom of patients with rheumatic disease, and we use pain for diagnose disease, assess disease activity, inform treatment decisions, and determine treatment response. And patients consistently rate pain as one of the highest priorities, and pain is the single most important determinant of patient global assessment of disease activity. More importantly, pain is also associated with anxiety and depression scores and with disease activity score. Pain, nevertheless, remains one of the most difficult symptoms to evaluate and treat. And I thought the cornerstone of rheumatic disease treatment is the suppression of inflammation used the treat-target approach. This remission will not lead to complete resolution of pain in all patients. It has been, for example, estimated that a substantial proportion of patients with rheumatoid arthritis still experiences relevant pain, although more than 80% of these patients are on biological treatment. With this premise, with this premise, a multimodal approach to pain management is very important, and this approach has been recommended by a Rheumatology Association. For example, you have recommended a patient-centered approach to pain management, where biopsychosocial framework should be adopted. As a major burden to patient society, novel approaches for the treatment of pain are needed to improve care of patients with rheumatic disease.
Right, so we got very interested in this because when you look at what drives the superiority of baricitinib over the gold standard of adalimumab methotrexate, upadacitinib over the gold standard, even in Finch 1, filgotinib, you couldn't show a difference in swollen joints, but the superiority was driven by pain, patient and physician global. So if these molecules can't cross the blood-brain barrier, as I was told or taught, how can that JAK-STAT pathway and the inhibitors of it be involved in at least central pain? Is it more peripheral pain? What do you think?
Yes, this is a very important point. There are only few studies demonstrating that JAK inhibitors in mice might overcome the blood barrier. However, the JAK-STAT pathway has been involved in the pathogenesis of rheumatic disease, but beyond the powerful anti-inflammatory effect mediated by JAK inhibitors, the use in clinical trials in real-life settings demonstrate a dramatic effect on pain. The problem is that possibly JAK inhibition might relieve pain in rheumatic disease caused not only by inflammatory mechanisms, but also by non-inflammatory mechanisms. And what we think is that the way of action of JAK inhibitors is JAK inhibitors inhibits pain not only acting on the pro-inflammatory cytokines, but also by directly mediating the JAK-STAT signaling in the context of peripheral nerves.
So tell us a bit about the nociceptive pathway and how the JAK-STAT inhibition might interfere with nociception. And then a new thing that we've recently is nociplastic, where chronic inflammation changes central connections.
Yes, we have several lines of evidence suggesting that the JAK-STAT pathway might be directly involved in the mechanisms that regulate nociception. We have data in animal studies demonstrating that alteration in JAK-STAT pathway are directly implicated in pain modulation. For example, JAK-STAT involvement has been demonstrated to be directly involved in models of pain in collagen-induced arthritis, and furthermore, spinal nerve lesions leads to rapid activation of the JAK-STAT pathway in dorsal spinal cord microglia in relation with enhanced levels of spinal IL-6. So it seems that beyond the role in modulating the concentration type 1 and type 2 cytokines involved directly in the induction of inflammation and also in pain, JAK-STAT pathway and JAK-STAT inhibition might be also important in the direct modulation of nociception, neural plasticity, and pain.
So should we make a differentiation between acute disease with acute inflammation and long-standing disease where nociplastic changes might have occurred? Is there any time that we should be aware of that this switches over, or is it different in different people?
This is a very good point. In the early phase of the disease, possibly the acute inflammation used by cytokines might be the predominant pathway inducing pain. Possibly in long-standing patients, patients with long-standing disease, modulation of neural plasticity, but also the centralization of pain might be the more important, the more determinant component in the pain feeling of the patients. Also in the long-standing disease, other factors might be involved in inducing pain, for example, the structural damage. I think that it is really a complex problem, and with the progression of the disease, the factors affecting pain are growing, and the complexity of the pain perception of patients is growing, and it is really hard to treat our patients, especially in the late phase of the disease, for these complex mechanisms that are playing together a role in nociception, induction of pain.
Is there any clinical is there any clinical tips you can give us to try and sort how much has now gone from inflammation to nociception pathways and nociplastic pathways, allodynia, or any clinical clues that might say, stop thinking about inflammation and start thinking about central sensitization and those other mechanisms?
Yes, there are some studies that might suggest a very important role of these drugs in modulating in a very wide way the pain in patients with rheumatic disease treated with JAKis. There is, for example, a recent study that evaluated the specific contribution of the effect of joint inflammation of one JAK inhibitor, tofacitinib, on pain relief. In this study, the author used the mediation modeling for examining data from tofacitinib trial. This mediation modeling attempts to understand the mechanisms behind an observed relationship and independent and dependent variables using other explanatory variables, for example, mediators. This model pain was the designated dependent variable, tofacitinib was the independent variable, and inflammation that was measured by swollen joint count and C-reactive protein was the mediator. It was found that 25% of the treatment effect of tofacitinib of pain was mediated by CRP, and swollen joint count was mediated by inflammation, indirect effect, but the treatment effect on pain not attributable to inflammation was 74%. So it is, appears to suggest that CRP, swollen joint count associated inflammation, might only partially account for the observed improvement of pain, for example, in patients with psoriatic arthritis, and other potential mediators and other potential factors, for example, neuronal plasticity, the centralization of pain might be responsible for part of the observed effect of JAKis on pain.
So do you think rheumos in general don't use enough tricyclics, pregabalin, other duloxetine, these other things that are used in chronic pain clinics for central sensitization? We don't use those, even opioids, we don't use those enough in our patients, especially with long-standing disease?
Yes, I think that these drugs are absolutely important in the treatment of the pain due to centralization of the nociception, the nociceptive signaling. However, what I think is that this class of drugs, JAKis, have this very dramatic effect on the pain component, which is the main reason why a patient goes to a rheumatologist, might suggest the possibility of a wider, but not only in long-standing patients, but also in early disease, the use of this drug in a wider number of patients affected by rheumatological disease. What I think is that the turning off the pain with this dramatic rapidity could result in a better personal and social outcome of patients, with also a substantial reduction in indirect costs related to this rheumatological disease.
Do you think any of our other drugs like TNFs, do they have central effects as well, or even peripheral pain effects? Do the original biologics, if you like, or the other classes of biologics also have some effect on central sensitization, or is it really inflammation only?
What I think, there are some studies demonstrating that also TNF blocking agents might have a role, at least in murine models might be a role on centralization, pain centralization. And one very interesting cytokine that might act also in this sense is IL-17, IL-17A. There is very nice study published on Immunity, if I don't remember bad, a few years ago, demonstrated in Cenorhabditis elegans that IL-17A signal is absolutely important, not only for the modulation of pain in direct way, but also in modifying the social behavior of the Cenorhabditis elegans. So IL-17A is a very promising, in my opinion, cytokines that might be specifically addressed and studied for this kind of problems in rheumatic diseases.
Interesting. I was looking particularly at the head-to-heads we've got, Spirit head-to-head and Exceed 17 versus TNF. And when you break the ACR components down, they change swollen joints in CRP and ESR just as much as the others. So it's quite different to what we see with the JAK. So that's interesting what you're saying about 17. Do you think JAKs should be then used in other chronic pain conditions? A topical JAK for post-herpetic neuralgia, painful peripheral diabetic neuropathy, reflex sympathetic dystrophy. Do you think we should try them in those other conditions?
Yes, this is a very, very provocative and interesting point, Peter. Thank you for the question. From a theoretical point of view, yes, the answer is yes. We need obviously more data for supporting this role, but from a theoretical point of view, my answer is yes.
Excellent. So tell us a little bit about your review and some take-home messages for the rheumatologists from your very excellent review in the Clinical and Experimental Rheumatology Journal.
Yes, thank you, Peter. What I would like to say is that pain is the most important symptom that the patients refer to a doctor, physician, to not only a rheumatologist, but other physicians. And we need to put more attention for pain, for the patient's reported pain, for the assessment of pain, and we need a very patient-centered approach to pain in our patients in order to give to our patients the best treatment available. JAK inhibitors for this very dramatic effect on pain are a very promising class of drugs that possibly in the next years we will try to use in a wider range of patients, not only for the important effect on inflammation and cytokine production, but also for the very, very dramatic and powerful effect on pain that remains the most important unmet need in the treatment of our patients.
Excellent. Thank you so much. We thank you again for your time, Professor Ciccia. This has been the CSF Author Interview podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, you can get detailed slide sets available in the publication section at cytokinesignaling.com. Please subscribe to this podcast, tell your friends about it. It's on iTunes and other podcast media, and give us some feedback and let us know what you think. And thank you so much for your time, Francesco. We greatly appreciate it. And we look forward to catching up face-to-face. With any luck, EULAR Copenhagen. Thank you very much.
Thank you very much, Peter. Thank you.